Good morning, one and all. Today, let's have a brief discussion on pulmonary edema. Pulmonary edema, it is a condition characterized by the accumulation of fluid in the lungs, which is caused by extravasation of fluid from the pulmonary vasculature into the interstitium and alveoli of the lungs. Pulmonary edema occurs in about 1% to 2% of the general population. Between the ages of 40 and 75 years, males are more commonly affected than females. After the age of 75 years, males and females are affected equally. The incidence of pulmonary edema increases with age and may affect about 10% of the population over the age of 75 years. Coming to the etiopathogenesis, pulmonary edema can be caused by the following major pathophysiological mechanisms. Imbalance of Starling forces, where there is increased pulmonary capillary pressure, decreased plasma oncotic pressure, and increased negative interstitial pressure, damage to the alveolar capillary barrier, lymphatic obstruction, disruption of endothelial barrier. Role of lymphatics. The lymphatics play an important role in maintaining an adequate fluid balance in the lungs by removing solutes, colloids, and liquids from the interstitial space at a rate of approximately 10 to 20 ml per hour. An acute rise in pulmonary arterial pressure, that is more than 18 mm of Hg, may increase filtration of fluid into the lung interstitium, but the lymphatic removal does not increase correspondingly. In contrast, in the presence of chronically elevated left atrial pressure, the rate of lymphatic removal can be as high as 200 ml per hour, which protects the lungs from pulmonary edema. It is classified into two types: cardiogenic pulmonary edema and non-cardiogenic pulmonary edema. In cardiogenic pulmonary edema, it is due to increased pulmonary capillary hydrostatic pressure secondary to elevated pulmonary venous pressure. In left-sided heart failure, there is decreased pumping ability to the systemic circulation, leading to accumulation and congestion of blood in the pulmonary area, which causes fluid leakage out of intravascular space to the interstitium, causing accumulation of fluid, finally leading to pulmonary edema. Cardiac disorders manifesting as cardiogenic pulmonary edema. Left ventricular systolic dysfunction is the most common cause of cardiogenic pulmonary edema, where there is decreased myocardial contractility, which reduces cardiac output. The fall in cardiac output stimulates sympathetic activity and blood volume expansion by activating the renin-angiotensin-aldosterone system, which causes deterioration by decreasing the left ventricular filling time and increasing capillary hydrostatic pressure. Left atrial outflow obstruction. This can be due to mitral stenosis or, in rare cases, atrial myxoma, thrombosis of a prosthetic valve, or a congenital membrane in the left atrium. Left ventricular dysfunction. Ischemia and infarction may cause left ventricular diastolic dysfunction in addition to systolic dysfunction. With a similar mechanism, myocardial contusion induces systolic or diastolic dysfunction. Chronic left ventricular failure is usually the result of congestive heart failure or cardiomyopathy. Causes of acute exacerbation of cardiogenic pulmonary edema: acute myocardial infarction or ischemia, patient noncompliance with dietary restrictions, patient non-compliance with medications like diuretics, severe anemia with underlying cardiac illness, sepsis, thyrotoxicosis, myocarditis, myocardial toxins, alcohol, cocaine, chemotherapeutic agents such as doxorubicin, adriamycin, trastuzumab, herceptin, chronic valvular disease, aortic stenosis, aortic regurgitation, and mitral regurgitation. Coming to the staging, the progression of fluid accumulation in cardiogenic pulmonary edema can be identified as three distinct physiological stages. In stage 1, the LA pressure is elevated, causing distension and opening of small pulmonary vessels. At this stage, blood gas exchange does not deteriorate, or it may even be slightly improved. In stage 2, fluid and colloid shift into the lung interstitium from the pulmonary capillaries, but an initial increase in lymphatic outflow efficiently removes the fluid. The continuing filtration of liquid and solutes may overpower the drainage capacity of the lymphatics. In this case, the fluid initially collects in the relatively compliant interstitial compartment, which is generally the perivascular tissue of the large vessels, especially in the dependent zones. The accumulation of fluid in the interstitium may compromise the small airways, leading to mild hypoxemia. Hypoxemia at this stage is rarely of sufficient magnitude to stimulate tachypnea. In stage 3, as fluid filtration continues to increase and the filling of loose interstitial space occurs, fluid accumulates in the relatively non-compliant interstitial space. The interstitial space can contain up to 500 ml of fluid. With further accumulation, the fluid crosses the alveolar epithelium into the alveoli, leading to the alveolar flooding. At this stage, abnormalities in gas exchange are noticeable, vital capacity and other respiratory volumes are substantially reduced, and hypoxemia becomes more severe, leading to flash pulmonary edema. Coming to non-cardiogenic pulmonary edema, it is caused by changes in the permeability of the pulmonary capillary membrane as a result of either direct or indirect pathological insult. Physiologically, non-cardiogenic pulmonary edema is characterized by intrapulmonary shunt with hypoxemia and decreased pulmonary compliance, leading to lower functional residual capacity. Common causes of non-cardiogenic pulmonary edema. Direct injury to lung is caused by chest trauma, pulmonary contusion, aspiration, smoke inhalation, pneumonia, oxygen toxicity, pulmonary embolism, reperfusion. Hematogenous injury to lung is by sepsis, pancreatitis, non-thoracic trauma, leukoagglutination reactions, multiple transfusions, IV drug abuse, cardiopulmonary bypass. Possible lung injury associated with elevated hydrostatic pressure seen in high altitude pulmonary edema, neurogenic pulmonary edema, and re-expansion pulmonary edema. High altitude pulmonary edema. In this altered permeability of the alveolar capillary barrier secondary to intense pulmonary vasoconstriction and high capillary pressure is seen. This in turn induces endothelial leakage which results in interstitial and alveolar edema without diffuse alveolar damage. In neurogenic pulmonary edema, it is a clinical syndrome characterized by the acute onset of pulmonary edema following a significant insult to the central nervous system. The etiology is thought to be a surge of catecholamines that results in cardiopulmonary dysfunction. CNS events associated with neurogenic pulmonary edema are spinal cord injury, subarachnoid hemorrhage, traumatic brain injury, intracranial hemorrhage, status epilepticus, meningitis, and subdural hemorrhage. Re-expansion pulmonary edema. It occurs in the setting of rapid expansion of a collapsed lung with acute onset shortness of breath, usually occurring within hours of re-expansion. The onset of pulmonary edema can be delayed by up to 24 hours in some cases. It occurs following approximately 1% of pneumothorax re-expansions or thoracentesis procedures. Patients may develop hypotension or oliguria resulting from rapid fluid shifts into the lung. Thus, it is advised not to withdraw pleural fluid more than 1.2 liters. Special considerations causing pulmonary edema are eclampsia, post-cardioversion, post-anesthesia, post-cardiopulmonary bypass, drugs like narcotic overdose, opioids, chemotherapeutic agents, salicylate intoxication, calcium antagonist overdose, hydrochlorothiazide overuse, radiocontrast media. Coming to the symptoms, there is patient will have severe shortness of breath, cough with pink frothy sputum, profuse sweating, cyanosis, anxiety, restlessness, palpitation, paroxysmal nocturnal dyspnea, orthopnea, chest pain, ankle and leg swelling. Signs: tachycardia, tachypnea, confusion, pedal edema, hypertension, crepitations, rhonchi, wheeze, S3 gallop, elevated JVP. Cardiogenic versus non-cardiogenic pulmonary edema. In cardiogenic pulmonary edema, S3 gallop is seen, elevated jugular venous pressure and peripheral edema are elicited. Cardiomegaly, engorgement of vasculature to the epiphysis, pleural effusion is common. Findings suggesting non-cardiogenic edema are pulmonary findings may be relatively normal in the early stages. Clinical picture ranges from mild dyspnea to respiratory failure despite chest X-ray showing diffuse alveolar infiltrates. Investigations: complete blood count, where be having severe anemia, serum electrolytes, hypokalemia and hypomagnesemia, pulse oximetry, hypoxia. Cardiogenic pulmonary edema responds to supplemental oxygen. ABGs were initially hypoxia and hypocapnia with respiratory alkalosis, later hypercapnia with respiratory and metabolic acidosis occurs. ECG shows tachyarrhythmia or bradyarrhythmia or acute ST elevation changes. Ultrasonography shows B lines where the sensitivity is 94.1% and the specificity is 92.4%. In cardiogenic pulmonary edema, chest X-ray shows cardiomegaly, curly B lines, basilar edema, absence of air bronchograms, bilateral and symmetrical pleural effusions. Treatment approach. In emergency conditions, proper position is advised, support of oxygen and ventilation, oxygen therapy, positive pressure ventilation. Reduction of preload and inotrope support by loop diuretics, nitrates, morphine. Condition that complicate P must be corrected like infection, acidemia, renal failure, and anemia. The most common synonym is LMNOP, where L stands for Lasix, morphine, nitrates, oxygen, and proper position. Treatment is focused on three aspects: improving respiratory function, treating the underlying cause, and avoiding further damage to the lung. Pulmonary edema, especially acute, can lead to fatal respiratory distress or cardiac arrest due to hypoxia. Patients with acute cardiogenic pulmonary edema generally have an identifiable cause of acute left ventricular failure, such as arrhythmia, ischemia, or infarction, or myocardial decompensation that may be rapidly treated with improvement in gas exchange. In contrast, non cardiogenic edema usually resolves much less quickly, and most patients require mechanical ventilation. Oxygen therapy. Support of oxygenation is essential to ensure adequate oxygen delivery to peripheral tissues, including the heart. When there is hypoxemia without hypercapnia, enrichment of the inspired gas may suffice and can be given either by nasal prongs or venturi mask with reservoir, depending upon the degree of oxygen enrichment required to elevate the partial pressure of oxygen sufficiently. If PO2 cannot be maintained at or near 60 mm of HD despite inhalation of 100% of oxygen at 20 liters per minute, or if there is progressive hypercapnia, mechanical ventilation is necessary. Non-invasive ventilation. Patients who do not have a response to initial therapy often require tracheal intubation and ventilation with the associated potential for complications. Non-invasive methods of ventilation can avert tracheal intubation by resting the respiratory muscles, improving oxygenation, reducing the work of breathing, and increasing cardiac output. Common non-invasive methods are CPAP and continuous positive airway pressure CPAP, or BiPAP, bi-level positive airway pressure. CPAP maintains single airway pressure support throughout the respiratory cycle, whereas BiPAP increases airway pressure more during inspiration than during expiration, which increases the patient's comfort. Mechanical ventilation. In refractory cases, mechanical ventilation can relieve the work of breathing more completely than non-invasive ventilation. Mechanical ventilation with positive end expiratory pressure can have multiple beneficial effects on pulmonary edema, which decreases both preload and afterload, thereby improving cardiac function, redistributes lung water from the intraalveolar to the extraalveolar space where the fluid interferes less with gas exchange, and increases lung volume to avoid atelectasis. Reduction of preload is by diuretics, most commonly by loop diuretics. Furosemide 0.5 to 1 mg per kg, bumetanide, and torsemide are effective in most forms of pulmonary edema, even in the presence of hypoalbuminemia, hyponatremia, or hypochloremia. Nitrates, these are the most effective and rapidly acting, which is given sublingual or intravenously. Started with 10 mics per minute, rapidly uptitrated to more than 100 mics per minute. 3 mg intravenous bolus are given every 5 minutes. Morphine given in 2 to 4 mg IV boluses. Morphine is a transient vasodilator that reduces preload while relieving dyspnea and anxiety. Nesiritide. This is a recombinant human BNP that decreases pulmonary capillary wedge pressure, pulmonary artery pressure, right atrial pressure, and systemic vascular resistance while increasing the cardiac index and stroke volume index. Afterload reduction is done by AC inhibitors, enalapril 1.25 mg IVs, captopril 25 mg sublingually, angiotensin 2 receptor blockers like valsartan and candicertin, nitroprusside. It is avoided in acute myocardial infarction. Prolonged use causes cyanide toxicity, tolerance, and reflex tachycardia. Inotropic and inodilated drugs indicated in patients with cardiogenic pulmonary edema and severe LV dysfunction. Sympathomimetic amines dopamine and dobutamine are potent inotropic agents. Bipyridine phosphodiesterase 3 inhibitors such as milrinone stimulate myocardial contractility while promoting peripheral and pulmonary vasodilation. In acute coronary syndromes like acute ST elevation MI, it is complicated by pulmonary edema, is associated with in-hospital mortality rates of 20 to 40%. After immediate stabilization, coronary artery blood flow must be re-established rapidly. When available, primary PCI is preferable. Alternatively, a fibrinolytic agent should be administered. Early coronary angiography and revascularization by PCI or CABG also are indicated for patients with non-ST elevation acute coronary syndrome. Coming to ECMO, extracorporeal membrane oxygenation. For patients with acute severe non-cardiogenic edema with a potential rapidly reversible cause, ECMO may be considered as a temporizing supportive measure to achieve adequate gas exchange. Usually, veno-venous ECMO is used in this setting. In high altitude pulmonary edema, it can be prevented by use of dexamethasone, calcium channel blocking drugs, or long acting inhaled beta 2 adrenergic agonists. Treatment includes descent from altitude, bed rest, oxygen, and if feasible, inhaled nitric oxide, nifedipine 10 mg sublingual or 20 mg sustained release 6 hourly. Hydrolazine acetazolamide may also be effective. Stimulation of alveolar fluid clearance. A variety of drugs can stimulate alveolar epithelial ion transport and upregulate the clearance of alveolar solute and water, but this strategy has not been proven beneficial in clinical trials so far. Prognosis. In hospital, mortality rates for patients with cardiogenic pulmonary edema are difficult to assign because the causes and severity of the disease vary considerably. In a high acute setting, in hospital, death rates are as high as 15 to 20%. Myocardial infarction, associated hypotension, and a history of frequent hospitalizations for cardiogenic pulmonary edema generally increase the mortality risk. Severe hypoxemia may result in myocardial ischemia or infarction. Mechanical ventilation may be required if medical therapy is delayed or unsuccessful. Endotracheal intubation and mechanical ventilation are associated with their own risks, including aspiration, mucosal trauma, and barotrauma.